the Anthelmintic drugs. Okay, so these are the one of the last topics from the chemotherapy. So today we are going to see first the helminthic organism, because unless and until you understand which are the helminthic organisms, you cannot understand the Anthelmintic drug. Remember, it is not anti, so in the spelling Anthelmintic drugs. Okay, then we will see the various drugs and their mechanism of actions like Mebendazole, Albendazole, Thiabendazole, Pyrantel, pamoate, piperazine. So there are quite few drugs in this category. Okay, so first we will see the helminthic organisms and then we will see about the various drugs. So in your microbiology you already learn the Helminths classification. Just I am going to quickly revise that. The Helminths, they are divided into the two, that is a nematoda or Helminths, means the worms having the round body, okay, and Helminths means worms having the flat body. Okay, so the nematodes is the one thing and Helminths means which having a flat body. This Helminths having flat body are further divided into the trematode and cystode. So there are total three types of the worms: nematode, cystode and trematode, and the drugs effective against them are also different, but there are some broad spectrum also which are acting on all three, but some are specifically acting only against the particular worms. Okay, so Helminths can be either the Helminths, that is a round body worms, or Helminths, that is a flat body worms. Nematodes. So first we will see the nematodes. This is very common infestation. Okay, remember, whenever it is a worm or Helminths, we call it as an infestation. Okay, while bacteria and virus we use the term infection. Okay, so nematodes, the first one which is a very common is a round worm. Okay, and the scientific name is a Ascaris lumbricoides. Okay, then the second is a hookworm. There are two species in that. One I have written here, Ankylostoma duodenale, and the second is Nicator americans. Okay, Ankylostoma duodenale and Nicator americans. Third is a whipworm. In whipworm, the scientific name is a Trichuris trichura. Okay, then threadworm and Strongyloides stercoralis. Then pinworm, that is the Enterobius vermicularis. Then filariasis. Okay, or we also call in a chronic stages this as a elephantiasis. There are two filarial organisms. One is a Eukaryotia bancrofti and second is a Brugia malai. Then onchocerciasis. Okay, it is also called as a river blindness. Mostly there is a visual impairment in this. That is scientific name is Onchocerca volvulus, of the worm causing this onchocerciasis. And the last is a guinea worms. In that is another scientific name is a Dracunculus medinensis. Okay, so these are all nematodes having the round body infestations. Most of them resides in the intestine, especially the first five, while the next filariasis and onchocerciasis, they are residing in the lymphatics or the blood. So some are the tissue nematode, some are the intestinal nematode. Then the next is a trematode. Okay, trematode are also called as a flukes. So there are various flukes. First is a blood flukes, and it is also called as a cystosomiasis because of the species name. So there are three species in this: Cystosomia mansoni, Cystosomia hematobium and Cystosomia japonicum, or it is also called as a bilharziasis. Then second is a liver fluke. There are two liver fluke. One is a Clonarchus sinensis, which is called as a Chinese liver fluke, and second is a Fasciola hepatica, which is called as a sheep liver fluke. See, most of the time this trematode and cystode, they are having the two hosts. So a human being is one of the hosts, and the second host can be anything like fish, dog, sheep or pork or beef. Then intestinal fluke, and the name is a Fasciolopsis busci. Okay, this you already all learned in the microbiology. Lung fluke is the Paragoniomiasis, that is the Paragoni westermani. It is a scientific name. So blood fluke, liver fluke, intestinal fluke and lung fluke. And the last is a cystode. Okay, so trematode and cystode both have a flat body, but what is the difference? The trematode, it is a non-segmented flat body, while cystode have a segmented flat body. Okay, and the segments of the cystode, they are called as a proglottis, while head of the cystode by which they attach to the intestinal epithelium is called as a scolex. So first is a beef tapeworm. Okay, if we are eating the undercooked meat, especially beef, then the man can get this infestation, beef tapeworm, and that is a Tinea saginata. Second is a pork tapeworm. Okay, the another name is a Tinea solium. Pork means सुअर, डुक्कर. So मैं इसको इस तरह से याद रखता हूँ कि सोलियम मीन्स अकेला, सो डुक्कर अकेला आता है, इस तरह से याद रखो. तो टीनिया सोलियम मीन्स पोर्क, टीनिया सजानाटा इज अ बीफ टेपवर्म. फिश टेपवर्म इज अ डाइफाइलोबोथ्रियम लैटम. ड्वार्फ टेपवर्म having a very short length, that is a Hymenoleuphis nana or H nana. And last is a hydrated cyst or disease which is caused by Echinococcus granulosus. Okay, hydrated cyst particularly occurs in the liver and lung, and most of the times it requires the operative treatment. So this is all about the worms: nematode, cystode and trematode. Now we will see the anti-helminthic drug. First we will see the mechanism of action of all in general, and then we will see the individual drugs. So anti-helminthic drug, they are either kill the vermicide, or they either kill the worms, that is called as a vermicide, or they either expel, that is called as a vermifuge. Okay, those which kill cause vermicide, those which expel cause as a vermifuge. 1/3 of the population harbors most of the worms or helminths, and it is most common in developing countries with poorer personal and environmental hygiene, because most of the time we acquire this infection through the infected soil, infected food or water. So a person, when he is not maintaining the personal and environmental hygiene. And most of the worms, they have their own excretory, digestive, reproductive system, but they depend on the host for their food and the various nutrition. So they consume the food what we are consuming, and because of that the patient may suffer from the another symptoms like anemia, weight loss, anorexia, abdominal pain. So these are the common symptoms, especially in case of the intestinal infestations. Now mechanism of action of anti-helminthic drug, it involve either of these four things. Okay, so either these drugs interfere with the neuromuscular function of the worms, because of which their paralysis occurs in the worms and they are expelled outside the body. Second, they can interfere with the microtubular functions. Microtubules are important for the locomotion or movement of the worms. Okay. Second, they can interfere with the calcium permeability. Mostly they enhances the calcium permeability. And fourth, they interfere with the energy metabolism, with the ATP production. So if the these parasites does not get the ATP, they will not survive and they will be expelled. These are the ant-helminthic drugs which we are going to learn today. In that, the first group is a benzimidazole. Okay, remember anti-amoebic drug metronidazole, it is a nitroimidazole. This is a benzimidazole. There are the drugs mebendazole and albendazole, and another two drugs are there, thiabendazole and triclavendazole. But these both have a very restricted uses, while mebendazole and albendazole, they have a very broad spectrum anti-helminthic drug. What do you mean by broad spectrum anti-helminthic drug? That apart from nematode, they are also active against certain species of cystode and trematode. That's why they are called broad spectrum. Next drug is a Pyrantel, pamoate, piperazine, levamisole, tetramycin, Diethylcarbamazine citrate, that is a DEC, Ivermectin, Niclosamide and Praziquantel. Okay. Now this is a chart which is also given in your book, Tripathi, that choice of drug for helminthiasis. So this is the most important part of the lecture. Okay, but I will just explain in a very short, and we will discuss this again in the last. So roundworm, that is a ascaris, you can see the first choice drug are mebendazole and albendazole. Hookworm, that is Ankylostoma duodenale and Nicator americans, Again, the first choice drugs are Mebendazole, Albendazole, okay, along with Pyrantel, pamoate. But we will discuss Mebendazole and Albendazole. They are preferred rather than the Pyrantel, pamoate because of certain side effects. Pinworm, that is Enterobius formicularis, again Mebendazole, Albendazole, okay. Threadworm we will discuss. Whipworm, Trichuris trichura, Mebendazole. Trichinella spiralis, Albendazole. Okay, so in general you can see that most of the intestinal nematode, roundworm, hookworm, pinworm, whipworm and Trichinella spiralis, all they have either Albendazole or Mebendazole as a first choice drug. Only threadworm, that is the strongyloids, have a Ivermectin as a drug of choice. Okay, and guinea worm, that is a Dracunculus melanoensis, as a metronidazole as a drug of choice. So metronidazole is actually not from Anthelmintic drug, it is anti-amoebic drug, but still it is a drug of choice for Dracunculus melanoensis. For filariasis, the drug of choice is not Mebendazole and Albendazole, it is a DEC, that is a Diethylcarbamazine citrate. While for threadworm, the drug of choice is Ivermectin. So we are going to see which are these exceptions in a detail. For the tapeworm or cystodes, Tinea saginata, Tinea solium, H. nana, the drug of choice is Praziquantel. So for cystode, it is a Praziquantel drug of choice, except neurocysticercosis and hydatid disease, where the drug of choice is Albendazole. So it can explain you that Albendazole, apart from nematode infestation, it is also a drug of choice in neurocysticercosis and hydatid cyst, which are actually a cystode infestation. And for most of the trematode, again the drug of choice is Praziquantel. Okay. Now the mechanism of action. First we will see the broad spectrum anthelmintic drug, that is Mebendazole and Albendazole. See, the cytoskeletal structure of nematode, it consists of microfilament, microtubules and beta tubulin. So just like we have our muscles and we have our legs for our locomotion or movement, the intestinal nematode or all other nematodes, they have a microfilament, microtubule and beta tubulin. So this beta tubulin, it is actually protein, and polymerization of beta tubulin will be responsible for movement of worms with the help of microtubules. So what these drug Albendazole and Mebendazole do, or benzimidazole do, they bind to beta tubulin, okay, and they inhibit their polymerization, because of which they disrupt the cytoplasmic microtubules and immobilization of parasite occurs. I am repeating, they bind to the beta tubulin and inhibit the polymerization of beta tubulin, because of which disruption of cytoplasmic microtubules occurs and immobilization of parasite occurs. Second thing they can do, they leads to irreversible inhibition of glucose uptake by parasite. So glucose is essential for their survival, that uptake of glucose will not occur. Apart from that, it causes depletion of glycogen store, reduced ATP formation, and because of which parasite death can occur. So this is the very important to remember. Mebendazole and Albendazole, they bind to the beta tubulin and inhibit their polymerization, and because of which the immobilization occurs. Secondarily, they also deplete, interfere with the glucose uptake, and they deplete the glycogen stores that will interfere with the energy metabolism of the parasites, and the parasites, they are then expelled. So remember, if you are killing the worms, vermicide; if you are expelling the worm, vermifuge. Then against nematodes. So nematodes, so these are the broad spectrum which we have seen. Now the drugs which are specifically active against the nematodes. So first we will see nematodes locomotor muscles has both excitatory nicotinic cholinergic and inhibitory GABAergic receptor. Remember, in human being, our skeletal muscles have only nicotinic muscarinic receptor, NM receptor, but in nematode, rather than NM, there is a NN, nicotinic nicotinic receptor on neuronal, and at the same time they have a inhibitory GABAergic receptors also. Now there are certain drugs which can stimulate the nicotinic cholinergic receptor and certain drugs which stimulate the inhibitory GABAergic receptor. We will see them. First is the Pyrantel, pamoate and levamisole. These are NN receptor agonist, okay, and they causes the release of acetylcholine. So by agonistic or stimulatory action on NN receptor, Pyrantel, pamoate and levamisole, they causes the release of acetylcholine. And at the same time, you know, acetylcholine is destroyed by which enzyme? Yes, acetylcholinesterase. So they also causes inhibition of acetylcholine esterase enzyme, because of which what happen, there is a release of lot of acetylcholine which will cause the depolarization, and because of excessive depolarization or persistent depolarization, neuromuscular blockade occurs, and that is called as a spastic paralysis. There are two types of paralysis, spastic and flaccid. In spastic paralysis, we are producing the lot, we are giving the entry to the lot of acetylcholine, because of which there is an influx of sodium ion and there is a persistent depolarization, and muscles will remain in a contracted stage and go into the spastic paralysis. That happens with the Pyrantel, pamoate and levamisole. So how can you remember? Plan. Okay, what is the meaning of this plan? P for Pyrantel, pamoate, L for levamisole, and they are acting on acetylcholine NN receptor, because of which they are producing the excessive depolarization and spastic paralysis. Okay. Then there is a second group which is exactly opposite of this, that is a piperazine and ivermectin. What they are doing? Piperazine, it activates GABA gated chloride channel. This we have learned in the CNS, that GABA receptor, it contains the chloride channel. Okay, but this GABA receptor gated chloride channel in the nematode, they are present in the periphery. In the human beings, they are present either in the brain or spinal cord. Here they are present in the periphery, and they are stimulated, because of which chloride influx will occur and hyperpolarization will occur. Okay, here we are producing depolarization with Pyrantel, pamoate. Here with piperazine, hyperpolarization because of entry of chloride, and that will produce flaccid paralysis. Paralyzed worms are expelled alive, and action is opposite to that of the Pyrantel, pamoate. That's why Pyrantel, pamoate and piperazine are never given together. Next drug is ivermectin. It acts on nematode specific glutamate gated chloride channel. Here they are GABA gated chloride channel. Ivermectin acts on a glutamate gated chloride channel. Okay, these are very specific only for the pharyngeal muscles of nematode. Remember, in human being, glutamate is an excitatory neurotransmitter, but in nematode it is acting as one of the inhibitory neurotransmitter through the chloride channel. Again, same, because of influx of chloride, hyperpolarization will occur and flaccid paralysis will occur. So you can remember this as a PIG. Okay, P for piperazine, I for ivermectin, and G for either acting on GABA and glutamate gated chloride channel. So both of these will produce the flaccid paralysis through hyperpolarization, and these two produce the spastic paralysis through the NN receptor depolarization. Next drug which is active against especially filariasis, Wuchereria bancropti and Brugia malai, that is a DEC. What is the long form of the DEC? Diethylcarbamazine citrate. Diethylcarbamazine citrate. It is a piperazine derivative. It acts on microfilariae of Wuchereria bancropti. Now the Wuchereria bancropti, it has a two, that is a microfilariae and it has a adult worms. So it is specifically active on microfilariae and very slowly active on adult worms. Okay, that is called macrofilariae. Micro and macrofilariae. There are three actions of DEC. It is a as it is a piperazine derivative, the same action of piperazine, that is a GABA gated chloride channel. So hyperpolarization and flaccid paralysis. Second, which is more important, is alteration of organelle membranes of microfilariae, which promote the cell death. So it causes the alteration in the membrane permeability of various organelles of MF means microfilariae, which promote the cell death. And third action of DEC is it blocks the prostaglandin production. Okay, so prostaglandin's production is blocked, because of which capillary vasoconstriction occurs, as prostaglandins are mainly responsible for vasodilatation of capillary. So by inhibiting them, capillary vasoconstriction will occur and there is an impairment of passage of microfilariae. Remember, this microfilariae, they mostly resides in the lymphatics or blood, okay, and they will cause the lymphadenitis or lymph node enlargement. So if you are going to inhibit their passage through the various capillaries, then further sequence will not occur. So this is the action of DC, out of which is important, alteration of organelle membranes of microfilariae. And the last is against the cystode. There are two drugs which are active against the cystode, Niclosamide and Praziquantel. So Praziquantel is preferred. So in the next slide we will see Praziquantel. What is action of Niclosamide? It uncouple oxidative phosphorylation. So in short, it will inhibit the oxidative phosphorylation. As you know, the oxidative phosphorylation is one of the last step in the synthesis of the ATP. So if this is inhibited, obviously ATP synthesis will be interfered. See, it inhibits the anaerobic incorporation of energy rich inorganic phosphates into the ATP, because of which energy metabolism of worms is interfered, and expulsion of dead worms in the feces. So this is the action of Niclosamide, uncouples oxidative phosphorylation and interfere with ATP. And the next and last drug is the Praziquantel. It is active against both cystode as well as trematode, okay, Miss flux. So what the Praziquantel do? It causes influx of calcium. So excessive entry of calcium inside the parasite from endogenous stores of cystode. So from outside also and from endogenous stores. So just like we have a sarcoplasmic reticulum, the nematode have certain endogenous stores of calcium, and the calcium will be released from that endogenous store into the cytoplasm. That results in the intense contraction of muscles and subsequent expulsion of the worms. So excessive muscle rigidity is produced, because of which these cystode and trematode will lose their grip on the intestinal mucosa of human being, and they will be expelled out of the intestine, especially through the feces. So this is the action of Praziquantel. Okay. So this is all about the mechanism of action of different worm. First, broad spectrum anti-helminthic drug, that is the albendazole and mebendazole. They will bind to the beta tubulin and they will inhibit the polymerization, because of which disruption in the microtubule function occurs. These microtubules, they are essential for locomotor movement or movement of the worms through the intestine, and that movement is interfered. Also they deplete the glucose uptake, and they also causes the depletion of glycogen stores, because of which the worms, they may die and they are expelled out of the intestine. So that is action of mebendazole and albendazole, binding to the beta tubulin and inhibit the polymerization. Second, Pyrantel, pamoate and levamisole, they are acting as a nicotinic receptor agonist of the cholinergic receptor, NN receptor agonist, because of which excessive depolarization will occur and spastic paralysis occurs, and ultimately worms will be paralyzed. Second is the piperazine and the Ivermectin. Piperazine is acting on GABA gated chloride channel, while Ivermectin is acting on glutamate gated chloride channel, both of which cause the increase in the chloride ions influx, hyperpolarization and the flaccid paralysis. Okay. Then the next is the Niclosamide. Niclosamide will uncouple the oxidative phosphorylation and it will interfere with the ATP production especially in the cystode. Okay. Then Praziquantel, which is active against both cystode and trematode, that is a flux. It will causes the excessive permeability or entry or influx of calcium ions from endogenous stores, and it will result in excessive muscle contraction. Apart from that, there is one action of Praziquantel also. It causes vacuolization of tegument. Tegument means parts of these flux. Okay, so mostly it causes the vacuolization of the teguments also, and that will interfere, also causes the expulsion of the worms. And the last is a DEC, that is a diethylcarbamazine citrate. There are three actions, but most important is the alteration of organelle membranes of microfilariae, which will promote the cell death. Okay. Now we will see the individual drug in detail. First is a mebendazole. It was from the group benzimidazole, which is introduced in 1972. Mebendazole is nearly 100% cure, provide the 100% cure rate in roundworm, that is Ascaris, hookworm, both species, means Ankylostomata duodenale and Nicator americans, Enterobius vermicularis, that is the pinworm, and Trichuris infestation. Remember, roundworm, hookworm. So roundworm mostly ingested through the food or the water. Hookworm, it may be ingested through the food or water, but mostly it enters when the person is walking barefoot through the soils. So hookworm can also cause another infection, that is the cutaneous larva migrans. Okay, so larva of the worms, they migrate and through the skin they can emerge. Okay, then Enterobius vermicularis, the characteristic symptom is a perianal pruritus or itching in the perianal region, because of which auto infection can occur. Trichuris trichuri, that is a weepworm. All these are having a 100% cure rate with mebendazole, but it is most less active on Strongyloides stercoralis, that is a threadworm. Here the drug of choice is Ivermectin, as we have seen in that chart. The mebendazole is also active on certain tapeworms like Tinea solum and Sajanata, but cure rate is 75%. While cure rate of Praziquantel is nearly 95 to 100%, that's why Praziquantel is preferred and not mebendazole. Okay, but it is active against tapeworms also. But against Hymenoleucus nana, it is relatively insensitive. Mechanism of action we have already seen, but just to revise, it will bind to the microtubular protein beta tubulin, and because of which it will inhibit the polymerization of beta tubulin, also blocks the glucose uptake, and the parasites will get immobilized and they will be the death of the parasite will occur. Coming to the adverse effect of mebendazole, it is well tolerated, so very less adverse effect. If occur, they can be diarrhea, nausea, abdominal pain. At a high dosage, it can cause certain allergy reactions and loss of hair. But safety during the pregnancy is unknown, because of which it should not be given in the pregnant female. Okay, and it is on the other side, it is contraindicated on the basis of animal data. So we don't have human data, but on the basis of animal data, mebendazole is contraindicated in the pregnancy. Now coming to the uses and administration. Okay, so mebendazole is given as a 100 milligram, available as a 100 milligram chewable tablets. So you can chew that tablet, and it is also available as a suspension in the liquid form, 100 milligram per 5 ml. Now what is the dose in the children above 2 years? It is same as for the adults. So this is very characteristic thing about the mebendazole. Okay, and also albendazole. Most of the time in the children we do the half dose, or we have a various formulas to derive the dose. But here, when the child is above 2 years, the same dose as the adults we have to give, while half of the dose for child of 1 to 2 years of age. While less than 1 year of age, mostly these drugs are not preferred. Okay. Now what is the dose of mebendazole, especially in a roundworm, hookworm and weepworm infestation, in nematode infection? 100 milligram BD for 3 consecutive days. This is very important, you have to remember this. 100 milligram BD twice daily for 3 days. This is the usual dose of mebendazole. Okay. While the another drug which we are going to see is a albendazole, it has a 400 milligram only single dose. That's why albendazole is preferred in all these 3 infestation as compared to mebendazole. Otherwise both are choice of drug. Okay, efficacy wise there is no difference, but dose wise albendazole is superior, because mebendazole we have to give 6 tablets, 100 milligram BD for 3 days. Now this is written, no fasting, purging or any other preparation of patient is needed. What is the meaning of this? Because the worms get paralyzed in the intestine and they can remain in the intestine there only. So sometimes we have to take the purgative or laxative in order to expel the worms or flush the worm. But there is no requirement of any purgative after using the mebendazole, no requirement of any fasting or any other preparation of patient. In heavy trichuriasis, means Trichuris trichura weepworm infestation, we have to use the 7-day treatment of mebendazole. Okay, Then in pinworm or Enterobius vermicularis, the dose regimen is slightly different. It is a 100 milligram single dose which is repeated after 2 to 3 weeks. Here we are not giving for 3 days 100 milligram BD. Only single dose of 100 milligram and it is repeated after 2 to 3 weeks. Why? To kill the ova that have developed later. Okay, so ova may develop after 2 to 3 weeks. So first we will kill the adult worm, and after 2 to 3 weeks we will kill the ova. So this is the specific about the Enterobius vermicularis. And remember, in Enterobius vermicularis, Mebendazole is preferred rather than Albendazole. This is the exception. Even in the Trichuris trichura also. So in these two infestation, Mebendazole is preferred. In case of Enterobius vermicularis, strict hygienic measures and simultaneous treatment of all children in the family is advocated to cut down the auto-infection, as there is a perianal pruritus. So auto-infection, the person infecting the himself again can occur, and person to person infection is also inhibited if we treat all the children in the family with the Mebendazole. Okay. Next is a trichinosis, that is caused by Trichinella spiralis. Here also dose is quite different, 200 milligram BD for 4 days, but here Albendazole is preferred, so it is a less effective than Albendazole. Hydatid disease, though it is given, it is not preferred, so let us not discuss that. Guinea worm, yes, Mebendazole is alternative to the metronidazole. So for guinea worm we have seen a choice of drug is metronidazole, but if metronidazole is not cannot be given because of some contraindication, then we can prefer the Mebendazole or Albendazole. Mebendazole is also more effective than Albendazole in trichuriasis. So we have seen that in trichuriasis and Enterobius vermicularis, Mebendazole is more preferred than Albendazole. Now coming to the Albendazole. Remember, in this chapter there are these two drugs have a main focus, Mebendazole and Albendazole, and last is a neurocysticercosis that we will see in the end. So Albendazole, it is a congener of Mebendazole. Advantage is a single dose administration and comparable cure rates in Ascaris, hookworm and Enterobiasis. So roundworm, hookworm and Enterobiasis comparable rate, but still in Enterobiasis somewhat higher efficacy of Mebendazole. This we have already seen. In trichuriasis it is inferior to the Mebendazole, while in strongyloidosis and Trichinella spiralis it is more effective than Mebendazole. Mechanism of action is same of Albendazole, that is the inhibition of beta tubulin. Oral absorption is enhanced with a fatty meal. This is a characteristic thing with Albendazole. When we are taking the Albendazole with a fatty meal, the oral absorption is get enhanced. That's why we are giving it with a fatty food to increase its absorption. Okay. And second thing related to the pharmacokinetics is that Albendazole gets converted into the sulfoxide metabolite, which is again active, and that exerts the potent Anthelmintic action, and because of which Albendazole is more efficacious in most of the infestations than Mebendazole, because its metabolite, that is the sulfoxide metabolite, is also active against the Helminths. Side effects are, it is well tolerated, so very few side effects, especially like dizziness, headache or fever. But if we are giving the Albendazole for more than 3 months, then it may cause the hepatotoxicity. Coming to the uses of Albendazole, no preparation or post-drug fasting or purging is required. So no use of no requirement of purgative after the use of Albendazole. For intestinal worms, means for roundworm, hookworm, whipworm, all other worms, it is given on empty stomach. While for cysticercosis, hydatid cyst, and for cutaneous larva migrans, where we require not a single dose but a doses for more almost up to 28 days, that we have to give with a fatty meal in order to increase its absorption. Okay. Ascaris, hookworm, Enterobius and trichuris, a single dose of 400 milligram of Albendazole is required, and this dose is same for the adults as well as in the children who are above the 2 years of age. Okay. While children between 1 to 2 years of age, dose required is a 200 milligram. For tapeworm, that is a cystode, and for strongyloidosis, the dose requirement is 400 milligram daily for 3 consecutive days. So same dose 400 milligram daily, but not for one day, it is for 3 days if it is a tapeworm and strongyloidosis. But remember, in strongyloidosis, Ivermectin is a drug of choice, and in the tapeworm, Praziquantel is a drug of choice. While in neurocysticercosis, which is especially caused by Taenia solium, larvae gets migrated into the brain. Rather than Praziquantel, Albendazole is a drug of choice. The only thing is that we have to give for more days, that is 8 to 15 days, sometimes even for the month, that is 28 days usually. 400 milligram BD. Here we are giving 400 milligram BD. Otherwise we are giving 400 milligram single dose in Ascaris hookworm and other infestations. This is the difference. Again, in cutaneous larva migrans, drug of choice is albendazole. So in neurocysticercosis it is a drug of choice. In cutaneous larva migrans it is a drug of choice. Here it is a 400 milligram daily for 3 days. Visceral larva migrans, again albendazole is a drug of choice. Hydrated disease, again it is a drug of choice, but here the requirement is for 4 weeks as the neurocysticercosis, 400 milligram BD. So visceral larva migrans, hydrated disease and neurocysticercosis, because they are the severe infection, we have to give the albendazole for 28 days or 4 weeks in a dose of 400 milligram BD. It can be given in filariasis as an adjuvant to the DEC or Ivermectin, because in filariasis drug of choice is a diethylcarbamazine citrate. So this is a second line drug, or can be given in combination with one of these two drugs. Okay. So you can see the albendazole has a broad spectrum of anthelmintic action, but it is contraindicated in the pregnant woman like mebendazole, and it should be given with caution in a patient with hepatic or renal disease. Okay. So this is all about both of these albendazole and mebendazole. So albendazole is preferred because of its single daily dosing, single dose 400 milligram OD in most of the mild infections of roundworm, hookworm and the others like the Trichuris trichura. Mebendazole dose is 100 milligram BD for 3 days in most of the infestations. That's why albendazole is preferred. Second thing, albendazole can produce the active metabolite sulfoxide metabolite, which makes it potent anthelmintic as compared to mebendazole. But in Enterobius vermicularis and Trichuris trichura, mebendazole is preferred, while in Trichinella spiralis, albendazole is preferred. This is about nematode. But with regard to neurocysticercosis, which is caused by Taenia solium larvae migrated to the brain, cutaneous larva migrans, visceral larva migrans and hydrated cyst, drug of choice is the albendazole. Okay, there is no role of mebendazole. There is a role, but it is very secondary. So albendazole is preferred. Both of the drugs are well tolerated, very less adverse effect, and whatever dose is in the adult, that is same for the children above the 2 years of age, while in the children less than between 1 to 2 years we have to halve the dose, while absorption is increased of albendazole if given with fatty meal or fatty food. Now moving to the next drug, that is Pyrantel, pamoate. This is not preferred nowadays, but it is having efficacy against the Ascaris, roundworm, Enterobius, pinworm and ankylostoma, that is a hookworm, which is comparable to that of the mebendazole and albendazole. Action we have seen, it is an NN receptor agonist, because of which causes persistent depolarization and spastic paralysis. Okay. Remarkably free of side effect, and single dose of 10 mg per kg is preferred for these infestations. Next, which is important, is a diethylcarbamazine citrate, and it was used in the 1948 for filariasis, okay, which is caused by 2 nematodes, either by Wuchereria bancrofti in 90% of cases or Brugia malai in rest of the 10% of cases. So these 2 nematodes will cause the filariasis, Wuchereria bancrofti and Brugia malai. Okay, what is the difference? Instead of larvae, they have a microfilariae. Okay, and adult swarm we also call them as a macrofilariae. Mechanism of action we have seen of DEC. There are 3 things: GABA gated chloride channel stimulation and hyperpolarization, alteration of organelle membrane. Here you can see alteration of organelle membranes of microfilariae, which can promote the cell death. Okay. And third is a blockade of prostaglandin production and capillary vasoconstriction. So it is a slow acting microfilaricidal. So it is cidal means killing the microfilariae. The dose of 2 mg per kg TDS means thrice daily. 2 mg per kg TDS means अगर daily dose देखा जाए तो कितना होगा 6 mg per kg. Okay, it clears microfilariae of both Wuchereria bancrofti and Brugia malai from peripheral blood in just 7 days. Okay. However, microfilariae which are present in the nodules and transudates, that is a hydrocele. Now this Wuchereria bancrofti or filariasis, it can mostly cause the infection in the lymphatics because the microfilariae gets migrated to the lymphatic, because of which elephantiasis can occur, हत्ती रोग. Okay, so पैर बहुत बड़ा हो जाता है, and it can also cause the hydrocele, that is a scrotum swelling. So hydrocele and elephantiasis, if it has already been occurred and present for long time, so microfilariae which are present within that transudate of hydrocele or in the lymphatic, they are not killed. So we have to give this drug in the early infestation. Okay, they can kill the adult worms slowly, that is a slow acting macrofilaricidal. This is the difference between Ivermectin and DEC. Both are active against this filariasis, diethylcarbamazine, citrate and Ivermectin. But Ivermectin not act on adult worm, it act only on microfilariae, while DEC acts on both microfilariae as well as adult worms. Apart from that, it is also active against the microfilariae of Loa and Onchocerca volvulus. Okay, but in Onchocerca volvulus, efficacy of Ivermectin is more than DEC. So in Onchocerca, Ivermectin becomes the drug of choice. So in filariasis caused by Wuchereria bancrofti and Brugia malai, DEC is a drug of choice, while in Onchocerca, Ivermectin is a drug of choice. This is the difference. So there are two uses of DEC. Okay, filariasis, and second is a tropical pulmonary eosinophilia. So in filariasis, DEC 2 mg per kg TDS. So we have to give this for the 12 days to 3 weeks, means for 21 days. So डेली डोज कितना हो जाएगा 6 मिलीग्राम. तो अगर 12 डेज के लिए देना है तो कितना हो जाएगा 72 मिलीग्राम पर केजी. और अगर 3 वीक्स मीन्स 21 डेज के लिए देना है तो कितना हो जाएगा 126 मिलीग्राम पर केजी. So total dose can be 72 to 126 milligram per kg of the DEC. Sometimes more than one course may be needed with a gap of 3 to 4 weeks. But if elephantiasis has occurred because of chronic lymphatic obstruction, the DEC is not that much useful because already the fibrosis has been occurred. Sometimes if there is a community transmission or the disease is endemic, this filariasis in the particular community, we can give the yearly treatment with a combination of DEC and albendazole single dose on a mass prophylaxis, so as to brought down the transmission of filariasis by reducing the microfilaremia or this microfilaria of the Wuchereria bancrofti. Second is very characteristic conditions, tropical pulmonary eosinophilia. Most of the time these patients have allergic cough and other causes have been investigated and nothing has been found. So this can be one of the etiology. So DEC can become a drug of choice in this eosinophilic lung, or called as a TPE, that is a tropical pulmonary eosinophilia. Okay, these larvae may migrate to the lungs and they can cause the allergic reaction like cough there. Okay, so DEC in the same dose for 2 to 3 weeks can provide the symptomatic relief. The adverse effect of DEC are common but they are not serious. So nausea, loss of appetite or headache can occur. But the one thing which is severe is a febrile reaction. So allergic reaction where the fever develops, rash, itching, enlargement of lymph node, bronchoconstriction or bronchospasm, and fall in the blood pressure because of mass destruction of microfilariae and release of antigens from microfilariae. So this is an allergic reaction or inflammatory reaction because of antigens released from dead microfilariae or adult worms. In this condition, we have to temporarily stop the DEC and we have to give the anti-allergic drug or anti-inflammatory drug like antihistaminic and corticosteroids. But it is seen that subsequent administration for the second time of DEC usually don't cause such a type of the febrile reaction. So for the second time we can give the safely. Next drug is Ivermectin. It is an extremely potent semi-synthetic derivative of anti-nematode principle which is obtained from this Streptomyces avermitilis. Okay, Streptomyces avermitilis is a source from which Ivermectin is derived, and it is a drug of choice as a single dose, only single dose, just like albendazole, 10 to 15 milligram for these two infestation, onchocercosis which is caused by Onchocerca volvulus microfilaria, and Strongyloid stercoralis which is a threadworm, is a nematode but not a filarial worm, sorry. So it is a drug of choice for this. It is asked as a MCQ commonly. Onchocercosis, that is a river blindness, and Strongyloid stercoralis, that is a threadworm, and it is comparable to the DAC for Bancroptian and Brugian filaria, but DAC is a drug of choice. It is microfilariacidal. It is inhibiting the microfilariae, but it is not inhibiting the adult worms, so not macrofilariacidal. So this is the difference we have seen in the DEC and the Ivermectin. It is also effective against the ascaris and cutaneous larva migrans, but again the drug of choice is albendazole. It is also useful in heavy trichuriasis as an add-on drug to albendazole or mebendazole. Certain insects like scabies and head lice, they are killed by Ivermectin. This is a very non-specific use of Ivermectin. Scabies which is caused by mite. Okay, so there is a one MCQ which is very classically asked. There is only one drug in the scabies which is given by oral route as a tablet form, and that is the Ivermectin. Otherwise all the drugs in the scabies, they are given by topically as a solution to be applied on the affected skin. The action of Ivermectin, we have seen that it causes the activation of glutamate gated chloride channel, and it will causes the hyperpolarization and flaccid paralysis. It is the only drug which is effective orally in the scabies and pediculosis, what I have mentioned you, and it has replaced the DEC for onchocercosis and has been used in the river blindness control program of WHO, especially in the Africa and Latin America. Okay, allergic reaction can occur to the Ivermectin also, just like DEC, because of degenerative products of microfilariae. In that case we have to give the antihistaminics and corticosteroids, just like we are giving about the DEC. The next drugs are Niclosamide and Praziquantel, which are active against the cystode, and Praziquantel is also active against the trematode. So it is highly effective drug against the cystode like Tinea solium, Tinea saginata, Diphyllobothrium latum or fish tapeworm, Hymenolopus nana, as well as pinworm. Mechanism we have already seen. It inhibits the oxidative phosphorylation or uncouple oxidative phosphorylation and interfere with the generation of ATP. Because of which what happens when the worms are injured by Niclosamide, they tapeworms Niclosamide. You can remember the Niclo. Okay, the tapeworms are partly digested in the intestine. Okay, so because of digestion of tapeworm in the intestine, they may cause visceral cysticercosis. Okay, these tapeworms, if they are digested again in the intestine and they are alive, they can migrate to the viscera or in the tissue, and that may be responsible for visceral cysticercosis. So this is a disadvantage with Niclosamide, so that's why it is not preferred in Tinea solium infestation. While Praziquantel does not lead to digestion of the worms in the intestine, and because of which visceral cysticercosis like neurocysticercosis will not occur, and it kills encysted larvae as well. So for Tinea solium and other infestation, drug of choice is Praziquantel rather than Niclosamide. This is the difference. Niclosamide causes the digestion in the intestine, because of which visceral cysticercosis can occur. For Hymenopilus nana, we have to give the 2 gram dose of Niclosamide for 5 days, and this is again disadvantageous because in this we can give only the single dose of Praziquantel, and that's on why the Praziquantel is preferred. But the most important thing is it is the safe during the pregnancy. So Niclosamide can be given safely during the pregnancy. Now the last drug in the Anthelmintic is a Praziquantel. It has a wide ranging activity against the cystosomes, means the trematode or flukes, other trematode like liver, lung fluke, liver fluke, okay, cystode, Tinea solium, Tinea saginata, hydrated cyst and their larval forms, but it is not active against the nematode. That's why it is not a broad spectrum. Mechanism of action of Praziquantel, we have seen that it will cause influx of calcium or excessive entry of calcium from endogenous stores of cystode, because of which excessive muscle contracture or rigidity occur and ultimately paralysis occurs. What will happen then? This tapeworm, they will lose their grip on the intestinal mucosa and they are expelled, especially the scolex or head of the cystode. They will lose the grip from the intestine. At relatively higher concentration, another mechanism of action of Praziquantel is vacuolization of tegument. That is the formation of vacuoles in the tegument or segments of these worms, and release of contents of tapeworms and flukes outside, because of which they will be deprived of nutrition, followed by their destruction by immune mechanisms of host. Okay, so whatever contents are released, they will act as antigen, and the host body, that is the human body, will produce the antibodies against them and they can be destroyed. So that is most important in case of the flukes or cystosomes infestation rather than cystode. One very important thing is that if Praziquantel we are giving for neurocysticercosis, okay, cysticerci of Tinea solium. Cysticerci means larval form of Tinea solium. When they are migrated to the brain, they can cause neurocysticercosis. And for neurocysticercosis, the epilepsy or seizures can occur, so we have to give the anti-epileptic drug, and for preventing the cerebral edema, we have to give the dexamethasone. So phenytoin, carbamazepine and dexamethasone, when they are given for neurocysticercosis, they will induce the Praziquantel metabolism, because these are all enzyme inducers, and they will decrease its bioavailability in neurocysticercosis patient, and that is a disadvantage of giving the Praziquantel in neurocysticercosis. Okay, that's why Albendazole is a drug of choice. So lastly, uses of Praziquantel in the various tapeworm infestation. Single dose has achieved 90 to 100% cure rate. Tinea saginata or Tinea solium, we have to give the 10 mg per kg single dose. So 500 mg or 600 mg tablet is available of the Praziquantel, which should be taken in the morning. Especially valuable in case of Tinea solium, because it kills the tapeworm larvae within the cyst and there are no chances of systemic or visceral cysticercosis developing. This we are comparing with a Niclosamide. Okay. While for Hymenopus nana and Diphyllobothrium latum, there is a single dose in the morning, but it is a quite high dose, 15 to 25 mg. यहाँ पे कितना है 10 mg per kg, यहाँ पे है 15 से 25 mg per kg. Okay. So first use is a tapeworms, all these 4 tapeworms, and second is a neurocysticercosis. So Praziquantel was the drug of choice previously, but now it is the second choice drug to the Albendazole. We will see in the coming slide. But both Praziquantel and Albendazole, they are contraindicated in ocular cysticercosis. If the cysticerci have migrated to the eye, both of the drugs should not be given. Okay. Third use is the cystosomes. All the 3 species of cystosome, that is Hematobium, Mansoni and Japonicum, they can be treated, but a quite high dose, 40 to 75 mg per kg. While for other foods, also drug of choice is a Praziquantel, except, this is asked as MCQ, except Fasciola hepatica, which is one of the sheep liver fluke. Here the drug of choice is either the Bitheanol or Triclabendazole. This we have to remember. In all trematode or flukes infection, that is a blood fluke cystosomes or lung fluke or Chinese liver fluke, that is Clonarchis sinensis, drug of choice is Praziquantel, except Fasciola hepatica, where it is a Bitheanol or Triclabendazole. Next, which is very important, on which very high chances of asking short note, is a Anthelmintic treatment of neurocysticercosis. So cysticerci or larval forms of Tinea solium, they can cause the cysticercosis of various organs including the brain, because of migration of Tinea solium larvae from the gut or intestine to the various tissues via the blood stream. Okay. Now this Anthelmintic drug, they kills the larvae or cysticerci, but after killing them, the antigens can be released and they can precipitate the inflammatory or allergic reaction which can cause the meningeal irritation, rise in intracranial pressure, seizures or epilepsy and other neurological phenomena. Okay, but we can prevent the future episodes or spontaneous due to spontaneous death of cysticerci. So we can prevent the occurrence of space occupying lesion, but this reaction can happen if we are giving the Anthelmintic drug. So now in all cases of neurocysticercosis, it is not necessary to give the drug. When the cysts are active or multiple cysts are present within the brain parenchyma or intraventricular, that is within third or fourth ventricle, and they are likely to enlarge and causes hydrocephalus, okay, excessive enlargement of the brain because of the accumulation of CSF, then these are better treated with Anthelmintic drug. But if the cysts are inactive and calcified, then they may be left alone. No need of giving the Anthelmintic drug like Albendazole or Praziquantel. Now, why Albendazole is preferred over the Praziquantel? Both are effective in killing the cysticerci, but Albendazole is preferred over the Praziquantel. There are 4 reasons. First, course of treatment with Albendazole is short, usually 8 to 15 days compared to Praziquantel course, that is a 15 to 30 days. So इसका कोर्स शॉर्ट है 8 से 15 दिन, इसका लॉन्ग है, इसलिए एल्बेंडाजोल प्रीफर करते हैं. लेकिन यहाँ पे एक एक्सेप्शन है, अगर सिस्ट बहुत ज़्यादा एक्टिव और मल्टीपल सिस्ट है तो एल्बेंडाजोल भी हमें 4 हफ्ते के लिए मीन्स 28 डेज के लिए देना पड़ सकता है. सेकंड, क्योर रेट्स इन टर्म्स ऑफ रिजोल्यूशन ऑफ सिम्टम्स एंड डिसअपीयरेंस ऑफ सिस्ट आर हायर 75 to 80% with albendazole than Praziquantel, where cure rate is only 50 to 60%. So cure rate is higher with albendazole than Praziquantel. This is second reason. Third, corticosteroids which have to be given concurrently in order to suppress the inflammatory or allergic reaction. It will enhance the absorption of albendazole, but it will lower the blood level of Praziquantel. So it will lower the absorption of Praziquantel. As we have seen, it is an enzyme induced drug. Again, phenytoin and carbamazepine also lower the Praziquantel levels, which we have to give in order to prevent the seizures in a patient of neurocysticercosis. Okay, so that is the advantage, that albendazole absorption is increased by corticosteroid like prednisolone, but it will on the other hand decrease the absorption of Praziquantel. Okay, and second, albendazole is cheaper as compared to Praziquantel. So these are the 4 things why the albendazole is preferred. Course is shorter, cure rate is higher, corticosteroid will increase the absorption, and it is cheaper. Now whenever we have to use the anti-helminthic, we have to first start with corticosteroid like prednisolone, either 40 to 60 mg per day, or dexamethasone like 8 to 12 mg per day 2 days before giving the anti-helminthic drug, and it should be continued till 2 weeks after completing the anti-helminthic course. Means 2 days पहले से prednisolone दो, फिर 4 हफ्ते या 2 हफ्ते तक albendazole दो, उसके बाद वापस 2 हफ्ते corticosteroid prednisolone देना चाहिए. ओके, एंड इन बिटवीन albendazole के साथ भी कंटिन्यू करना है in order to suppress the inflammatory reaction to the products of killed larvae. Absorption of both is enhanced by fatty food. Albendazole and Praziquantel, both absorption is enhanced by the fatty food. For patient with seizure, we have to give the phenytoin and carbamazepine apart from the albendazole. Parenchymal cysts, they respond to the albendazole with a course of 8 to 15 days, while intraventricular and subauricular cysts require the month dose, that is mostly for 28 days. Very important to kill and expel the adult worm from the gut to eliminate the source of future cysticerci. So this is all about the this topic, anti-helminthic drug. These are the very highly MCQs on this topic. So we will just revise. Albendazole is a drug of choice for all nematode infestations, including cutaneous larva migrans, which is also called as a creeping eruption, visceral larva migrans, which is also called as a toxocariasis, and neurocysticercosis, which is caused by Taenia solium. So drug of choice is albendazole in all nematode infection like roundworm, hookworm, pinworm, threadworm. Okay, but the only thing is that exception is pinworm. Okay, so except Enterobius vermicularis or pinworm, where drug of choice is mebendazole. Filariasis, which is caused by Wuchereria bancropti and Brugia meli, where the drug of choice is diethylcarbamazine citrate. Strongyloid stercoralis and onchocerca valvulus, where the drug of choice is Ivermectin. And Dracunculus medinensis or guinea worm, where the drug of choice is metronidazole. Okay. Then Praziquantel is a drug of choice for all trematode, that is flukes and cystid infestation, except Fasciola hepatica or sheep liver fluke, where the drug of choice is triclabendazole, and hydatid disease or hydatid cyst, where the drug of choice is albendazole. Next important point from this lecture is that DEC, diethylcarbamazine citrate, acts on both microfilariae as well as adult worms, whereas Ivermectin acts only on microfilariae. Okay. So this is all about the Anthelmintic drug, and there are very highly chances of asking the short note why albendazole is preferred over Praziquantel for the treatment of neurocysticercosis, and there can be a short note on mebendazole or albendazole, and MCQs as we discuss on the various choice of drug. So thank you guys.